mod A first, so like I did neuro, I never got to do it as a placement. So it's kind of just about maybe picking up on signs, not knowing what they are, and then looking at it later and kind of just not getting too bogged down in not knowing stuff. And there was just like a few bits of advice about like how to approach patients and just like knowing their name first. Like I know that sounds stupid, but doctors will just say to you like go see bed 12 and do a cardiovascular exam. Like they'll show up and be like, who are you and stuff. So yeah, but we can like move on. So I was going to sort of ask everyone, like what you're kind of looking for when you first call that patient and they like walk to the room with you. So I guess you've done neuro. So if you are, you know, call a neurology patient into clinic, like what sort of stuff would you look for as you're even just taking them to the room?
Just their gait, any limping or like foot drop, things like that. Or they have a walking aid, you know.
Yeah. So like mobility aids or like just getting any help from someone, like their facial expression, you know, if they're visibly in pain, or I guess like for A&E, like just having a bit of a clock if they're angry or upset, just for your like own self. Yeah, gait. So exactly what you said, like stride length, like is it an ataxic gait? Is it got the asymmetry of Parkinson's? And then also, I guess their speech can also be something that you can look at. So are they like, you know, confused with Alzheimer's or delirium? Are they mumbling? You know, just like picking up on little things. I think especially as well, it kind of makes you clock if you should be taking a collateral history alongside it if you're going to get like a reliable history from the patient. And then just clarify who's with them. And just a piece of advice, like never assume that someone is the wife of someone or the daughter or something, because like you can get it wrong and it's so awkward. It's unbelievably awkward. And then just like get them comfortable in the room. But it's like fairly self-explanatory. So I was going to do like a picture quiz of like is coming up of like a assessment of the hands, which I think is like quite an important thing to start off on. So just a general like, you know, feeling if they're warm or cold, you know, if the circulation's good. You'll know dwarfs from your neuro exam, and like from previous stuff, right? Like that acronym.
Yeah.
Okay, good. And then I think a few of these are more to do with like kind of rheumatology, orthopedics, like movements and stuff. But I guess with like neuro, you might see specific like territories that are wasted from like nervous injuries. So it's always like a good thing to clock. So if we go next, I've got some hands. I really don't expect like if like there's any that you don't know, like it's totally fine. Even just describe to me what you see that's wrong, even if you don't know the reason for it. But just like take your time, like have a look at them and see if there's any that you recognize from the wards.
I see some clubbing, top middle.
Nice, yeah, clubbing.
Tar staining to the right of that.
Yeah.
To the left of that, is that muscle wasting or some sort
of which one?
To the left of the clubbing.
So what's kind of odd about those hands? Like do you notice
they're in a weird position?
Yeah, so it's almost like the position of the fingers is like going the wrong way. They're kind of like this rather than like this. And it's basically rheumatoid arthritis. So they get this, it's called ulnar deviation. So their fingers move this way.
Okay.
And they get the swollen metacarpal joints, which are here.
Oh yeah.
And they get there's a few specific that you can like learn in mod B, but just to be aware of, like you see the thumbs are quite unusually shaped, the joints. It's called like a boutonniere's deformity, but essentially it's that the joints have basically, because of inflammation, become like almost dislocated essentially. So that might be something you'll see in a lot of your elderly patients. You probably would have seen it and not noticed, or noticed it and not realized what it was. Okay, so bottom left, if I told you, you may have probably come across this in PALS just because it's a very like common like SBA thing that they say, not as common in real life, I think. But this would be in like a cardiovascular exam that you'd see these.
Is this splinter hemorrhages? No.
Yeah, so there's splinter hemorrhages in the nails. And then if the patient was complaining, if you see the kind of dark patches on the actual fingers,
yeah,
they'd basically complain that these are really, really painful. And it's another sort of infective endocarditis type lesion that you might see in the hands.
mm-hmm.
It's called they're called that Osler's nodes. So I just remember it as like Osler is ouch, Osler is painful. So I think I have that written.
The middle one.
Oh, sorry. Yeah, that's palmarothema. So that's kind of another mod B one, like you might see it. It's in liver disease and things. And then Dupuytren's is more obvious in real life. If you feel their hands, you'll feel a really, really tough tendon. So it's always good to like just check the palm of the hands because it can be a bit subtle.
Okay.
But yeah, Osler's is ouch. So like already you can pick up a disease from like not even getting to the rest of the patient essentially. And obviously if you see clubbing, you should be thinking of quite a sinister cause. And sort of by the end of the year, you'll know all of the different causes of clubbing. But I think, you know, if you get to cardio and you just learn the cardio ones and then you learn the resp ones and stuff and just build it up, I think that's quite a good way to learn them.
Cool.
Splinter hemorrhages, like I've highlighted the ones that you probably just need to know, but as much as infective endocarditis will always come up in SBAs because it's kind of interesting. But like the most common thing would be like, you know, you've got a builder who's gets them on his hands that he uses to hammer stuff in. You can also get it in lupus, interestingly, but they're just essentially like small clots in the nails. And that's kind of what it is. But I think like you can just look at this another time, to be honest. And then the really small writing is because it's just not necessary. Cool. Oh, cool. We have someone else. How exciting. Yeah, please, like, feel free to turn on your mic. Like, it's a bit of a picture quiz. Okay. So yeah, I mean, you might see these if you're starting renal next week on your like renal dialysis patients, they get them as well because they've got a bit of a deranged clotting thing going on. So I think we can like move on. I think splinter hemorrhages, like at this point, it's like unnecessary to sort of get bogged down in the details, so we can like move on. So once you've done your hands, you've assessed those, you're gonna look at the arms and you're going to do your pulse, your blood pressure and stuff. I'm not really going to dwell on them, to be honest, because I think a colleague can go over it in a sort of cardiology based way of the, you know, different abnormalities with pulses and stuff and blood pressures. But obviously, like if they've got a painful arm, probably now would be an appropriate time to do an elbow or a shoulder exam. And also like with neurology, right, you'd compare like the musculature of both sides. So if they'd had a stroke, you might look for like wasting on one side due to like lack of use of that side. So but let's move on to the fun pictures because like that is what we live for. So starting from, well, just kind of go for whatever, I think. But yeah, the bottom left, the muscular guy, there's actually nothing wrong with him. So, well, he's muscular, but don't think there's like scapular winging because like there isn't. But I'll mention it why I've put that there in a bit.
Edema, the bottom right.
Yeah.
Unilaterally. Muscle wastage, top middle green box.
Yeah.
Is that a rash? Is that a specific kind of rash?
So the left one is on like the flexor surface of the elbow. It's very itchy. It's very common. It's associated with asthma and things as well, and allergies.
Eczema.
Yeah, so it's just like to be aware of that if someone's got eczema and you're in a respiratory clinic, they might have asthma as well, and that's why they're there. So it's kind of good to ask someone who you notice that on if they have any asthmatic symptoms ever. Yeah, you were right, like muscular wasting. I mean, it's pretty dramatic. One, I've put it as deltoid, but I think it's more like the triceps from thinking about it now. With the edema at the bottom. Oh, sorry, did you ask something?
What's the one next to the right of the muscle wastage?
So you might
Oh,
see this,
breathing.
you'll see this on renal. So this is it's called an arteriovenous fistula. So for hemodialysis patients, they basically make an abnormal connection between an artery and a vein. And they're super cool. You should go and if you like feel it with your finger, it will like buzz, which is quite interesting. And they basically do this so that they can connect up their hemodialysis to give it. And they start very peripheral and they'll go, not the, they're not going to put it in the palm. But they start peripheral and they go like more and more central. So you might see the scars on a renal patient going up. The one thing to bear in mind with clinical practice is do not ever take blood from it. Do not ever try and cannulate it because you'll just destroy it. And it's like the one thing that probably a renal doctor would like scream at you for, but they'll probably tell you that as well. Oh yeah, it will probably explode, but they're cool to go and feel because they buzz, which is quite cool. Okay, so top right is something to be more aware of. Do you know, like you might see this in the acute setting?
IVU?
Yeah, so it's like the track marks, and it's good. Something to bear in mind is that often these patients might also be injecting into their legs and their ankles, and they can ulcerate at the site. So you might see it a bit on vascular surgery, but also in acute med that you kind of want to check. The doctors might check these patients' legs to look for sites of infection.
Okay.
With the lymphedema, so it's like, yeah, it's lymphedema. Do you have any idea why it would be sort of one-sided?
Lymph node damage to that side.
Yeah. So if it's so this is a lady, and if she's got a history of cancer, would that sort of give you any kind of clue as to why she will have had this? That you might not, to be fair.
They have the lymph nodes removed to prevent
Yeah,
metastasis.
yeah. Like really common is like in breast cancer surgery that they'll do the microscopic surgery of the lymph nodes in the axilla, and it's pretty debilitating lymphedema, but they'll get it there, and then if it's like a gynae cancer, they'll probably have like lymphedema of the leg as well, or be more prone to it. So it's more often an iatrogenic, like something that we've done that's caused this than a congenital cause. Okay, and then this lady who's at the gym, have you ever seen what's on her arm before? You might have seen it in children a bit more, maybe.
Is that maybe an insulin pump or something?
Yeah, so like always good to be aware of. I mean, diabetics will usually, I mean, if it's pumped, it'll probably be better control, but diabetics can come in with in pretty bad states, so it's always good to clock that someone has one, and it might tailor your history to ask about sort of complications of diabetes later on. And then I've thrown in this guy who's been at the gym a load because you'll learn a bit more in Mod B, but having a high, and you'll get this in renal medicine, that basically a high muscle mass increases your creatinine levels because it's like produced by the muscle. And I think you weren't here when James did his session, but it's just something that can up your creatinine just because it's a byproduct of muscle essentially on your blood tests. So it can be flagged as abnormal, but actually, if you've got a patient in front of you that's super muscular, it's probably down to that.
Okay.
Cool. Yeah, well done. Like literally, like I wouldn't have got half of these like at all. So you've done your arms, and then oh yeah, sorry. So it's probably tricep wasting to be honest, if I had to guess. Yeah, insulin pump. Okay, so this was just to say that I mean I guess COVID times it's like no one's the examining that you're doing is maybe a bit more minimal. But it was more to just say that like I think especially as a guy, I think you'll get this probably more in like obs and gynae or something in 5th year, but It's just that patients do refuse being examined. They do refuse being examined by doctors. I mean, I've had patients who've like refused, like rectum examinations when they've got like an obvious GI bleed, stuff like that. And I think it's not getting offended, not taking it to heart, I think is what I mean more, that like it's nothing to do with you if a patient like refuses. And if they're rude to you, like that's not like your fault. It's just that some people just don't treat you very nicely. And in real life, if this happens to doctors, they'll document the refusal to kind of cover themselves, but just like be prepared that that could happen. I mean, sometimes it's more of a like cultural reason about modesty and things, and it does happen to women as well. I mean, I was in like a few members of the Orthodox Jewish community the men don't have physical contact with women, and so they don't want to be examined by a female doctor. So can kind of happen to both sides, but just to be aware and like not let it kind of throw you off piece, essentially. Okay, so that was kind of just like a little bit, but when you do examine other areas, there are a few kind of like tips and tricks that doctors told me kind of over the years, but sorry about how grim some of these photos are, but so going on from Our Lady with the insulin pump, the top left might be a complication of diabetes that you might look for and that you should look for, especially in elderly patients with like long-standing uncontrolled diabetes, is ulcers. And these will commonly come at places of pressure points. And it's mostly down to the fact that you might have covered this a bit in neuro, that they lose sensation from kind of like glove stocking distribution. And so they get an injury they don't notice and it gets infected. So it's always good to look. Do you know what the top middle is showing?
Cellulitis.
Yeah. And do you know why they've like drawn on it in pen?
They can track the spread of it, or how quickly and how large it gets.
Yeah. And so like what makes you more sure that this is cellulitis as well as it's just one side? It's not really ever bilateral. So if someone asks you why it's cellulitis, it's because it's like one-sided as well. It's never really both legs. It just spreads from like one place. This was a tip that I was given when doing a cardiovascular examination, especially on the elderly who've had lots of they could have had lots of interventions basically, is to always feel for the presence of this, which is on their left side of their chest. Do you know what that could be?
Pacemaker.
Yeah, so it's always good to feel, because honestly they just forget. Like I don't know how, but they do sometimes. So it's always good to just have a feel and check. And also this guy, you can see faintly, he's got like a midline stenotomy scar where he's probably had I mean, he's either had this pacemaker put in an open fashion, or he's had some sort of like bypass as well. So it's just always good to be aware of like the surgical scars that you'll look out for in certain patients. And then I've put this here sort of regarding like body habitus, that being both underweight and overweight carry risks for certain diseases, especially in like the cardiovascular setting, like being able to note like someone's weight in a sensitive way can kind of point you towards like more sinister pathology, I think. And also like a sudden gain or drop in weight can also be quite a big risk for things like pancreatitis, is kind of one that you'll eventually learn about. And also someone drops dramatically in weight, they'll have lots of loose skin and you might be concerned about a malignancy. So it's like always good to note it. And then I don't know if you'll get this. Like, I'd be really impressed if you do, honestly, this like early. But this is the same rash, but on different skin tones, and it's a scaly plaque-like rash that goes onto the extensor surfaces and on the back. And it's also associated with like arthritis.
Is it psoriasis?
maybe.
Yeah,
Oh, wow.
psoriasis. And it's just like, I think, good for practice to look at how different, I think for year 4, just learn like the rashes that like relate to the conditions of 4th year, basically. So like psoriasis will come up in rheum, but just have a look at how different they can look, I think. And I think you'll get that as well from just meeting patients with conditions, but it's just something to bear in mind. So cool, you've smashed it again.
No, don't.
So okay, so onto the face. So again, like, I think we won't do cranial. I mean, you've done neuro recently, but we'll do cranial nerves in a separate lecture because it's a pretty long examination, even for like slick doctors who've been doing it for years.
Yeah, I'm just wondering how long you have for us in a station for that, because it literally takes me like 20 minutes to do a full neuro in the ward.
Yeah.
30 minutes, it takes so long.
I think that in previous years they do like a 10-minute station, but they'd only do like a certain number of nerves. So they do like, I don't know, they do all the eye stuff, but Anush is probably the one to ask because we didn't have a OSCE last year.
You're usually given 5 minutes and you're given certain cranial nerves to test. So we were given a visual field exam, and that was 5 minutes long.
Okay,
Where you
cool.
test the movements of the eye and the visual fields and nothing else.
Right, okay.
It's so unlikely that they will give you a full cranial nerve exam, because they honestly, examinations, a 10-minute station on examinations is a bit of a waste, because the thing they try to keep the 10 minutes for is histories.
History should only be 10 minutes. It takes me like 20
These are usually 10 minutes because they like doing a proper history.
It takes me like 20 minutes to do history. Oh,
how many weeks in are you though? It's fine.
Yeah, honestly. And also it's very different taking a history from a patient that's on the wards versus an actor or a patient that's been basically geared up to talk to you. So, you're going to go off on tangents. You're not going to do it in like the set order in real life, but in an OSCE, like you should be prepared to do it in the order.
Oh, right, okay.
But I wouldn't worry about it at all. I just get like, experience taking histories from patients, and presenting them, I think, is super helpful. But I wouldn't worry at this point in the game, like about how quickly to do it on OSCE. I think you'll get quick by doing them thoroughly and properly at the start and taking your time.
Okay, cool.
It'll be good. It'll be good.
Last thing, patients and OSCEs have a very set script, so they won't go off on one.
Right.
So, like, you know how when you're talking to patients, they'll talk about their past medical history for like 10 minutes or something.
Yeah.
In an OSCE, they'll be like, "Oh yeah, I have hypertension and diabetes," and then stop.
And they'll say their drugs. They won't like describe the name or whatever. Like they will know the drugs in the OSCE. So, and there won't be the usual, 12 or something. There'll be like 4. So it'll be okay.
Right.
Okay, so I've got some more photos. So not expecting you to get all of these. It is a bit Mod C-ish though, this. So some of them are diseases, but some are just like signs. So just kind of just go for what you think.
Let's see. I forgot the fancy word, but the eyes are bulging out. Is it
It's
exophthalmos? No?
Yeah, exophthalmos. And what do you see that in? High something.
It's a thyroid problem.
Yes, it's hypothyroidism or Graves' disease.
Graves, yeah, that's it. Graves' disease.
And there's like quite a good there's photos on Google, and there's a quite dramatic like before and after photo. So you see that how much better they get after treatment. What do you make of the photo to the left of her?
Alopecia, is that alopecia?
Yeah.
And then I see facial nerve palsy, Bell's palsy, I guess.
Yeah.
Is it right?
And
So I put alopecia in because that can be a symptom of lots of things, well, presenting complaint of lots of things, but also in hypothyroidism. So that might be something that you'll see in clinic. So the young guy, you might not know this, the young guy on the right is illustrating that certain genetic conditions can have certain facial features.
Yeah.
So this guy has like the long chin, pointed chin. He'll have a really long arm span, be very tall, have long fingers, have a high arched palate, and he'll be more at risk of certain cardiovascular problems, including aortic dissection.
Is it gigantism?
Kind of similar. Like I would definitely think that if you saw him, you would have that up there. It's actually like a so gigantism is it's like a pituitary tumor often that is present in children before their growth plates have fused.
Yeah.
So they get proportional stuff, and it's not usually a sort of genetic problem, it's more of a like malignancy. Whereas this guy's got a genetic problem, and you'll come across it in cardio, but it's Marfan syndrome.
Oh, I've never heard of that one before.
You'll hear all about it. But basically it's a collagen problem. So they interestingly are very, very tall people who have problems with their blood vessels. So they can become like weak and they can dissect basically. But like you're on Mudsey, like you probably won't have heard of it. It was probably covered in like the depths of first year, if that, to be honest.
Okay. And then SLE and hirsutism on the bottom.
Yeah, so SLE is actually the one on the left of.
Yeah.
Is that the one you meant?
The middle
The
one.
middle.
Yeah, that's SLE,
Yeah.
right? The butterfly.
Yeah, so she's got amazing. Yeah, malar rash.
On the right.
Yeah, so this lady has Cushing's. So she's got a rounded face, and she's got some hirsutism as well. So there's quite a lot of endo on this slide.
Gotcha.
Now,
Muhammad Ali.
Yeah. So I put this in because you might have met some of the patients that had what he had. Do you remember what Muhammad Ali ended up developing?
No, I don't know what he had. I forgot.
So he had Parkinson's disease, which may or may not have been caused by the boxing. He might have had sort of traumatic Parkinson's, but I don't know. Did you meet any Parkinson's patients while you were on the wards?
The problem with Queen Squares, I've only seen the atypical Parkinson's, so I actually don't know what normal Parkinson's looks like.
So it's worth I found YouTube quite helpful for looking at gaits of Parkinson's patients. But one thing that they get is because of the problems with movement, they also get problems with movement of their face and their facial expression. So they get this, it's called like a Parkinson's mask. And I brought this up because sometimes because their movement is so minorly affected, you sometimes speak to them and you think, is there something I've said? Have I upset them? They just don't seem very engaged. And actually it's their Parkinson's. They can look super serious, but they're actually, it's actually something with their disease. So that's why I sort of threw my in, just to mention. But yeah, I think the slight problem with Queen Square is it is just so, you just don't see the kind of normal side of neuro.
I've only seen rare things.
And interesting interventions usually. So yeah, alopecia, Graves, Bell's palsy, Marfan's, Cushing, SLE, Parkinson's. Okay, to reassure you of the eye stuff that you need to know for this year, because it does come up a smidge, but to be honest, you do ophthalmology in 5th year, and the only things that are really covered are kind of in a GP setting and just things that are specific to certain conditions that you might come across. So for GP, they'll kind of expect you to know by the end of the year, and we can help you with this because it's quite easy to learn the stages of them. It's quite sort of categorical, and Anuj has some really amazing slides. but it's basically just like diabetic retinopathy, hypertensive retinopathy, and then a few things that are like specific to certain diseases. And I think it helps just to know slightly what they are ish, just to remember them. But like, you don't need to learn cataracts really, you don't need to learn glaucoma really, like any of that stuff until fifth year.
Okay.
But I put in a few. Some of them are a bit more subtle than others.
Is it called a squint? What's the proper name for a squint?
It's strabismus.
Business. Okay.
So yeah, the top guy is strabismus, and like I put it in because I think it's an often isolated anomaly, and is correctable. But you know, sometimes it slightly remains in adulthood, and so just to not confuse it with something like more sinister, I suppose.
Okay. Is that a cataract in the bottom right? No?
Yeah.
Is it normally, are their eyes normally that dilated, or is it because of the light?
I think that they've probably had this taken in an ophthalmology appointment where they dilate your eyes. I don't know if you've ever been.
Okay. Yeah.
Makes your vision all blurry, but that's probably why they've done it.
And then I see one in the bottom left, one eye is more constricted than the other.
Yep.
Or one's more dilated than the other. I don't know which one's which, but.
And do you notice anything about like the way that one of the eyes is positioned?
Ptosis on one of the eyes.
Yeah, on the left one, yeah.
So what is that? Is that
So it's ptosis, meiosis, and would you say like this is a down and out pupil? Would you say it's slightly slightly? So you might have come across it in neuro, possibly.
Yeah, I'm trying to remember the name. It's like is it just pressing on the sympathetic chain or something?
Yeah, so you can get like a Pancoast tumor that causes it, but what's the syndrome called?
Give me a sec.
That's all right. If you think about what the Vikings wore on their helmets, I think it was the Viking.
What?
This is like the most. I'm trying to. It's good, maybe like actually like they had something on their head.
What, Horner syndrome? Holy
yeah, literally. I thought that was quite good, and then I doubted myself that the Vikings had them. It's like, was it the Vikings? A bit off there.
Horner syndrome, that's a classic. Easier question. Holy shit.
Yeah. SBA world, they love it. Okay. So on the left, this is not like Sauron's eye, but it is a very angry eye. And you might not know this, but it will come up in rheumatology quite a lot.
No, that's not it.
Begins with like a U.
Uveitis.
Yeah, so this is kind of what it looks like. So things like inflammatory bowel disease, like.
Is that picture upside down, by the way? Is that like, I don't know. It looks upside down to me for some reason.
I think like the whole eye is also swollen, and I'm not convinced that like this is just. I mean, Anish will have to wade in because I haven't done ophthalmology, but like I think the whole eye is also a bit swollen, so it looks really weird.
I think this is just really, 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 really bad anterior uveitis.
You can get a posterior uveitis.
So posterior uveitis is a thing that you don't need to know about. Not even next year. You only need to know of anterior uveitis at any point in med school.
Okay, and then the one on the right hand, is that Wilson's disease or something? Really?
Oh, I mean, so like Wilson's no, but like you're on the right lines. Like what organs Wilson's?
Yes.
Yeah.
No,
so
the iris is really tiny. I thought that was like cover or something.
Yeah, to be fair, I think so. Normally with like Kaiser Fleischer rings, you have to use like the slit lamp. I think this is just a really quite bad quality photo, to be honest. But yeah, this is jaundice, and it's most easily seen in the eyes, to be honest. Was kind of the take-home message for that.
I'm not sure what the top middle is.
It was conjunctival pallor, but like the photo is rubbish. But that's always a good one to look at because like everyone is anemic all of the time. Well, no, it's just an easy one to check for in your exam. Okay, so I did a bit on the mouth because I was straight up like I feel like we're never taught anything about the mouth. It's sort of like left to dentists. Yet like patients will present with like mouth pathology, and I think like we don't need to know like all the ins and outs of it, but I think we do need to sort of recognize what's like normal and what's not normal. And also it is related to other systemic diseases. Like they've found that poor oral hygiene is an increased risk of cardiovascular disease. It's also related in like the etiology of rheumatoid arthritis as well. So, and just more simply, they could come up with like a tooth abscess, an infected tooth. They can also have mouth organisms that go and colonize other areas of the body. So I think it's like fairly-ish important enough for you to just know some like basics, I think.
Okay.
I mean, I have straight up said there's good dentition occasionally in front of a patient because I felt bad. It's a bit of a like, you've got to word it very nicely, I think.
Well,
Oh,
sometimes
yes.
will like have a little banter with you.
Yeah. So yeah, they just say it how it is. But
okay.
sorry about the sorry about this grim slide.
Okay. I see a bit of, is that Candida? Bottom middle, I guess.
Oh, so it's not. It's like far more sinister than Candida. So Candida is thrush, and you would see that probably like on the top of the tongue, and it kind of looks a bit kind of yeast. Well, it's yeast, but like yeasty, cottage cheesy kind of stuff. Whereas this is like on the base of the tongue, and this is called leukoplakia.
Never heard of it.
And it's like a prequel to like mouth cancer, so it's like pretty bad.
Okay.
It would be an increase. You probably see it. Probably more likely to see it in kind of like immunocompromised patients. Could be more at risk of developing cancers, so that might come up possibly. To the left of it, it might not be too obvious because I couldn't get the best photo, but another thing to do for assessing if someone is jaundiced is to look at look into their mouth at like their hard palate.
No way.
Because especially in darker skinned individuals, it can be quite subtle, the jaundice, or you can't see it at all. And when I was on like hepatology, it was a kind of source that you can look at for adults if you're unsure and just need confirmation, but get a good like pen torch to see it. Top left, the syndrome came up earlier, but can you just sort of tell me what's weird about this?
Just a standard cavity.
Yeah, so okay, so there's the black bits of the teeth, but do you notice how like the palate kind of goes up to a little turret? I had a patient with Marfan's once say that their palate looked like a cathedral.
Oh wow.
So they get this high arch palate. So like if you see someone who's super, super tall, it is always worth just have a look in their mouth because there's very few things that would cause that. Don't know what else I'm like aware of that can cause that, but yeah.
Okay. I'm not sure what the rest are, not gonna lie.
So the top one it's called like black hairy tongue. And it's a side effect of one of the antibiotics called tetracyclines, which you might end up learning about.
Is that rare, a side effect?
Noosh. I don't know. I mean, I think it's how many
Comes
patients.
up in exams.
Okay.
Sorry, what was that?
Comes up in exams.
Oh, okay. Good to know. Black hairy tongue, tetracycline.
Yeah.
And then the top right, if I said that this was a beefy red tongue that was big.
Hypoglossia, I guess.
Yeah.
Beefy tongue looks like? I don't know.
It was the closest I could get. And do you know what you kind of see that in which deficiency?
Oh, yeah. A B12?
Yeah. that will come up in hematology, like I'm sure they'll ask you. And then the bottom is, so you kind of touched on it almost earlier, but this is an endocrine problem where a patient would complain of their shoes no longer fitting, their hands getting bigger, their face changing, getting more kind of coarse facial features, and they get this spreading out of their teeth. Do you know what that could be?
That would be gigantism, or acromegaly rather.
So acromegaly, yeah. So they can get this interesting kind of spreading out of their teeth. I mean, whether you're like ever going to see that is like another thing, but it's just to kind of illustrate like how the mouth can also be interesting and not just to dentists. Oh, it's actually pretty common. Oh, sorry.
Acromegaly.
I think it's just like with COVID, I've just like forgotten how common things are. But yeah, that was kind of like the end of what I was going to talk about. And I think it's just to like, you know, give everything a go, and you're going to, it's better to take things slow now and do them properly, and then build up and get more confident and be able to do things slicker, because you will be able to do multiple things at once. I think when you're on acute medicine, you'll see people do kind of a combination of all of the exams in quite a nice way. And I think like you'll just get more confident and better, and you'll pick stuff up, and you won't always know the reason for it, but like, you know, like we're going to be here like every Thursday, so if you see something and you want kind of more teaching on it or more info, like feel free, because it's always interesting.
It's super cool. Thank you so much. Thank you.
That's all right. And like